high-level discussion about what it is, so in case people aren't familiar with it. Then we're going to get into a little bit more details. Can you hear me in the back okay? Yeah, I'll try to project. Okay. So back in 2001, my partners and I looked around us and we said, you know, for everything that's being said about achieving triple aim and quality and looking at measures and process and procedure and how we do things in medicine and reducing error rates, there's one thing that's missing. There's one secret sauce that's missing from that equation, and that's the love between the patient and the physician in a relationship. The primary care physician receives love in the form of gratitude, and the physician gives the patient love in the form of the care that we give them while they're sick. And for everything that's being said about this achieving the triple aim, that's been left out. And so we said, you know, we've got to figure out how to make sure that that's preserved in healthcare. Because if we don't, we're never going to achieve high quality, cost-effective care. And we said, you know, it really starts with time. Time is the currency of excellence. And if you want to be excellent at anything, you must spend time in order to achieve it. And for a physician, that means time with the patient. Time to communicate, which in medicine allows us to arrive at a true diagnosis and a true treatment plan. Without time and communication, you can't form that critical component of high-quality, cost-effective healthcare, the relationship. And if you don't have love exchange in that relationship, you're bankrupt. You'll never be able to achieve the triple aim. And so on that foundation, we began forming this idea of direct primary care. And essentially, it's very simple. We get that time with the patient because the payer, whoever they may be, pays a bundled fee instead of a fee-for-service fee. Fee-for-service misaligns the incentives in the equation, and which we'll see a little bit later in the talk, and it degrades the physician-patient relationship. So, over the years, we've continued to grow that model. And actually, across the country, direct primary care is growing tremendously. Not only in the individual market where people are just buying it, but also now in the form of on-site and near-site clinics with employers paying for part of the fee, the membership fee. And we're seeing tremendous growth in that area. And it's not your typical thought of on-site clinic where it's occupational health. It's full-on primary care and all of the services that are offered within the direct primary care bundle, which we'll talk about in a little bit. So let's start with an overview of what we're going to be talking about. We're first going to talk about the changing stakeholder relationships in healthcare as we move from healthcare 1.0 to healthcare 2.0 to healthcare 3.0. Healthcare 1.0, for the purposes of our talk, is prior to 1950. And healthcare 2.0 is 1950 to 2016. And healthcare 3.0 is after 2016. I'm going to describe that in terms of a diagram that we use in medicine where we put the patient in the center and then we put the relationships in that person's life as bubbles around the patient. The closer that bubble is to the patient, the more important that relationship is, the more influence that relationship has on the patient. And the further away they are, the less influence and less intimate form of the relationship. And then we're going to talk about the employer's healthcare dilemma. This is a big problem that the employers have. And it's not just employers. Every stakeholder, as we move from the paradigm of volume in healthcare 2.0 to value in healthcare 3.0, have a serious problem. And there's going to be winners and losers. And for those stakeholders who don't understand their role in this paradigm shift, they'll lose, and they'll lose big. And I'm going to focus, I could talk about each stakeholder individually and what they need to do in order to survive this paradigm shift. But because we're really all employers here, I'm going to focus on just the employer side. essentially, and I'm going to talk too about where we are in healthcare 2.0 and why employers can't buy value from their healthcare supply chain. Think of whatever company you're in, you have supply chains. Whatever industry you're in, you have supply chains. Well, one of your biggest supply chains is healthcare. And for most of you, you're likely spending, that's one of the highest expenses in your company, next to payroll. And if you think about healthcare as one big giant supply chain, you're not buying value from it. We're going to talk about that. And then finally, we're going to talk about healthcare 3.0 and the SALTA direct primary care solution that's part of that. And it's not just the primary care physician, it's the employer that's part of it, and it's the patient-centered technology that's part of it, part of that solution. So let's start. How many here think that the problem that we have with healthcare is that we simply don't spend enough money? Right? Yeah, that's the main problem, right? That's a big number, $3 trillion. We spend $3 trillion on healthcare every year in our country. $1 trillion of that $3 trillion is going to rotate out of healthcare 2.0 and be invested in healthcare 3.0. $1 trillion. That has huge implications for all the stakeholders in healthcare, because that rotation has to occur among every stakeholder. Hospitals have to make unique investments in order to survive healthcare 3.0. Specialists do. Diagnostic testing centers do. Insurance companies do. Employers do. Employers have to, in order to survive this transition from healthcare 2.0 to healthcare 3.0, they're part of that $1 trillion that needs to rotate out of investments they're currently making in healthcare 2.0 and invest in healthcare 3.0, investing in value. So let's start. So we're going to start with healthcare 1.0, prior to 1950. Jerry, I'm sorry.
I'm on.
Okay. I'll send it to you later.
Thank you.
All right. So here we are. This is what it comes down to. The primary care physician and the patient in a relationship together. They call medicine the jealous mistress, because as primary care physicians, we didn't go into this for money. You know, the job's great, but we work terrible hours and don't get paid well. We do it because of the relationship that we have with the patient. And it's incredibly satisfying to care for people in that context of that relationship, and the gratitude you receive in that gratitude and love is tremendous. But prior to 1950, that relationship was present, and you have to remember, prior to 1950, it was largely a free market, cash-only experience. Even up to 1970, as much as 80% of healthcare services were all paid for out of pocket. And so let's bring in the rest of the stakeholders. So you'll see in the dotted line, patient-centered technology. Prior to 1950, there really was no patient-centered technology. And when I say patient-centered, I mean the patient is interfacing with technology for the betterment of their own health and wellness. There really wasn't anything. And then we had specialists. There were primary care physicians, and for the things you couldn't do, you got a consult with a specialist. Medical technology was just starting to take off. All the great things that we do in healthcare, the high technology, the diagnostic testing, and those sort of things. The government was largely not involved in healthcare. Government was way out from the patient. Pharmacies were way out. There were no medications, right? So there was no influence, no interface between pharmaceutical companies and the patient. Insurance companies, again, really not part of the equation, way out, way out. Hospitals, again, in this relationship, the patient and the physician collaborated to discuss what were the best things for the patient. Do you need to be in the hospital? Do you need to have the surgery? Do you need to see a specialist? The primary care physician guided them through that process. And then the employer was really not part of the equation as well. They were way out, except for in the early 1900s, the on-site clinics with the railroads and the coal mines and those sort of things that industrial companies began to implement. So let's go to healthcare 2.0. So between 1950 and 2016, there were tremendous changes that occurred in our healthcare system. It was a paradigm shift. And what I'm going to do is I'm going to go through each of these players, each of these stakeholders, and show you how their relationship to the patient changed. So first, again, this occurred over time, but the primary care physician was largely removed from the equation. Nowadays, you have 5 minutes to see a primary care doctor, if you see him at all. You're likely to see a nurse practitioner or a PA who have 2 years of training versus 7 years for a primary care physician. So the relationship has been largely displaced in this volume-based paradigm of healthcare delivery. We're only now really beginning to see technology forming in the patient-centered technology area. And you see that with Asset Health. And yesterday David said, well, explain to me why you're working with Asset Health. Well, I can tell you why I'm working with Asset Health. We're integrating them into every one of our direct primary care clinics because of virtue. It's a virtuous company, all the way from the top through all the managers, the way they do things, and their purpose as virtue. They have the same goals that we do in terms of redefining the delivery of primary care and health care in this country and using technology to do that. Well, let's see what happened to specialists. Specialists moved way in on the patient. We became a more specialized experience in healthcare. Well, I've got to see this cardiologist, I have to see this gastroenterologist, I have to see this person, this person, this person. The rise of specialties began to occur. Not always with the best results. We also saw medical technology move in. The rise of nuclear medicine scans, MRIs, CAT scans, all this high-cost diagnostic testing that began to be used. Of course, the government's moved way in, right? I mean, with the passage of the Affordable Care Act, the government's poised to move to a single-payer system. Pharmaceuticals. Pharma's has a huge influence on healthcare. Not just the individual patient. I mean, you see ads all the time on TV for pharmaceuticals. Everybody's got to have pharmaceuticals, right? Everybody needs a drug for something. Insurance companies move way in. Instead of an actuarial business, which is what insurance is, they're trying to become healthcare companies, right? They're trying to actually deliver the care. And in the way that they finance, especially primary care, they're actually getting in the way of the physician-patient relationship. Again, pushing primary care physicians out. Hospitals hugely influencing. The American Hospital Association and their lobbying and their influence in local demographics. What are the first questions people ask when you go to the doctor? What's your insurance? And what hospital system do you use? In Southeast Michigan, one of the biggest health systems, Beaumont Health, they had a wildly successful advertising campaign that says, do you have a Beaumont doctor? That was the big campaign. So hospitals have become hugely influential. And then you'll notice I left employers out there, right? Because why did I do that? Well, you guys are paying the bill, right? But you don't have any influence. You don't have any control over the delivery or the cost of your healthcare supply chain. So you're really still out in the outside, right? At the end of healthcare 2.0. So let's see what happens in healthcare 3.0. Again, if each of the stakeholders don't figure out how to survive this paradigm shift, there are going to be a lot of losers and a lot of winners. And if you think about it in terms of the employer space, the best way to create value is by investing in healthcare value for your company. Because if everyone in your industry is competing on the same level playing field, and your company's figured out how to make this paradigm shift and others haven't, you're suddenly created tremendous value in the company compared to your competitors, and they'll actually potentially go out of business. That's the power that we're talking about here. companies in Healthcare 3.0 have to realize that healthcare is not a cost item. Healthcare is a value item. They need to invest in healthcare in order to create value within their company and make them competitive within their industries. In Healthcare 3.0, the direct primary care physician moves back into their place around the patient, a steward of the healthcare dollar and healthcare for the patient. They're a trusted partner in accessing healthcare services. This is only going to be possible with the rise of patient-centered technology, which is Asset Health. It's through that patient-centered technology, interfacing with that technology, through the collection of biometrics, through communication, through education, through all the great things that this technology can bring to bear, that empowers the direct primary care relationship and makes it what it can be. Specialists are going to move out. There's going to be less need for specialists because the direct primary care physician is going to be able to take care of 80% of the person's healthcare needs right there in the office. And if we need a specialist, we'll do a virtual consult. I'll bring a cardiologist up on a screen using technology to do a consult, because a lot of times primary care doctors, we just need access to the specialist's cognitive skills. It wastes everybody's time for them to go and see the doctor and go through that whole process. Well, they have to, because that's how the doctor bills insurance, right? Not in Healthcare 3.0. In Healthcare 3.0, the primary care physician is driving the ship. So if we need a specialist, we're able to get it and do it in a way that's efficient and cost-effective. Same thing with medical technology. Study after study shows that there are many diagnostic tests that are simply not needed. MRIs for back pain, CT scans, nuclear medicine scans. There's way overutilization and duplication of services in Healthcare 2.0. And you guys are paying the bill. When somebody comes in to see the primary care doctor and I write an order on a prescription, I'm not writing an order, I'm writing a check out of the employer's checkbook, right? I mean, most are self-insured, right? So that money's coming right out of their bank account. Government is going to move out as Healthcare 3.0 takes form. Now, this is if it doesn't happen over the next 15 years, the Healthcare 3.0 taking form, the government won't move out. The government is going to go to a single-payer system. So this is a battleground. The next 15 years will determine healthcare in this country for the next millennium. Pharmaceutical companies, they're going to move out too, because we're going to talk with the patient about cost-effective medications. We're going to dispense medications for pennies in the office and pass that savings on to the consumer without all the markups. We can carry right within our office 80% of the medications that we generally use in primary care. The courses of antibiotics, lisinopril, diabetic medications. These are, for pennies, we can pass this on to the patient. Insurance companies are going to move out. We don't need them. What part of insurance companies creates value in healthcare? All we need is a TPA. We just need a third-party administrator to adjudicate the claims. So insurance companies, again, tremendously disruptive. I mean, you're hearing about insurance companies getting out of healthcare, not going on the exchanges, because they realize in Healthcare 3.0, they need to go back to just being an insurance company, not a healthcare company. Hospitals are going to move out too. And what's amazing to me is that I've met with all the major health systems in Southeast Michigan. We're about ready to sign an affiliation agreement with another one. We have one with Henry Ford Health System. But at the very tops of these health systems, they still don't understand Healthcare 3.0. They're building new towers. They're building more beds. We've got to have more volume, more volume. You look at these hospitals and they're like palaces. And they don't realize that in Healthcare 3.0, hospital admissions are going to drop by over 20%. Emergency room visits are going to drop. They're going to actually need less capacity. They're not realizing they need to take that investment. Instead of investing in more infrastructure to serve volume, they need to invest in creating infrastructure to deliver value in healthcare. And then you see the employer is going to move back in, or is going to move in. The employer is going to take a much stronger role in healthcare 3.0 because they're the fuel. The employer is the fuel of healthcare 3.0, the direct part from primary care physicians, the provider of healthcare 3.0, and patient-centered technology empowers healthcare 3.0. So that's the new paradigm shift, and that's why it's so important that employers realize their role in healthcare 3.0, because the problem all these stakeholders have is that they have limited resources, right? It's not, just like David said yesterday, he was spot on. As soon as your chief financial officer realizes you've saved money in healthcare, that money is going to be invested somewhere else. And the thing that has to be, made clear at the highest levels of companies is that that investment has to be taken out of healthcare 2.0 and invested in healthcare 3.0 to survive. Any questions on that part before I go on? I'm going to try to get through the whole thing and leave a little time at the end, too. Okay. Let's move on to the employer dilemma. You are required to provide health care. It's the law, right? But you're required to provide it for other reasons. It's the most valued benefit that your employees have. This is a monster survey that was done, a study that was done that showed that 32% of people ranked healthcare benefits as the top benefit that they value. But it's more than that. If you want a healthy, productive workforce, you need healthy patients. Well, and that have intention to wellness and mindfulness and well-being. And if you want to attract top talent and keep top talent, you need healthcare too. So no one would argue that you are required to provide healthcare. You just can't say, well, it's not important to us. No, that's not an option. So you have to provide something that you have no control over its delivery. This is the current health supply chain that you're buying in healthcare 2.0. You're buying inefficiency, poor outcomes, poor service, lack of communication, high error rates, lack of clinical practice guidelines, economics are based on volume, poor population management, dysfunctional fee-for-service economics, no relationship between quality and price. There's absolutely no relationship in healthcare between the quality of what you're buying and the price of what you're buying. Everybody gets paid the same. So this is the reality. And I could go on and on for hours just with the problems in today's healthcare system, but we're not going to have enough time for that. So you also have no control over its cost, right? This is what you're looking at. In 2000, these are actual numbers by Truven, the health analytics benefit modeler that we put in. So this is 2010 for an average 1,000 employee company. And we made it 1,000 because you might be sitting there and say, well, I have 500 employees. Well, cut it in half. Or I have 2,000, double it. I have 5, right? These numbers are staggering. In 2010, $5.6 million. 2016, $9.2 million. How many companies are going to survive $12.1 million in healthcare costs for their companies? It's untenable. It seems like a problem with no solution. Now, employers have tried lots of different things, right? We've tried, mixing things up, shifting costs to the employees, but that's not an option either anymore, right? Household income in 2002, $55,807. In 2015, $53,657. Household incomes have dropped, but the healthcare costs for a family of 4 are up over $10,000. How do you raise a family of 4 with $53,000 and paying $10,000 in healthcare? The gig's up. There's no more shell games that can go on. The only way to survive this is to move to healthcare 3.0. And it's going to take bold leadership at the top levels of companies in order to achieve this. As I was saying, if you look at the different players in healthcare 2.0, there's overutilization. Most ER visits are avoidable, 42%. 42% of ER visits, which if you look at your claims analysis and cost drivers, ER visits are going to be at the top, or it's going to be a big one. Because people are ending up there because they can't get into a primary care doctor's office, or they don't have a relationship with a primary care doctor, so they're ending up there, and 42% of them are avoidable. Remember how I talked about the specialists moving in Healthcare 2.0? Over the past 10 years, there's been a 94% increase in the utilization of specialists. And you know what happens when they end up in the specialist's office, like the cardiologist? Well, you've got to have a stress test, you've got to have an echocardiogram, you've got to have this, you've got to have that. And why do you got to have it? Because I own the machine. And that's the kind of stuff that's going on. They're just turning this volume wheel. It's like the patient is this vessel through which everybody gets paid. And so, and your guys are writing the checks. So the percentage of primary care services referred to higher cost specialists, 40%. So 40% of the time someone ends up in a primary care doctor's office, they're ending up in a specialty office. Why are they doing that? Because the primary care doctor is seeing 30 patients a day. They don't have time to spend with the patient to figure out the problem. All they're doing is say, you go here, you go there, you go here, you go there. And so the amount of referrals are way higher than they need to be. In direct primary care, we can cut that number in half or more in reducing the number of specialists and care for the patient ourselves with better, if the same, if not better outcomes. So this is the supply chain, 2.0 supply chain. And for people who might not know, this is the triple aim equation, okay? And now we're talking about the quadruple aim, which adds physician satisfaction. Because, again, a primary care physician who's stressed out, who is just trying to survive and get through the day and keep their lights on because they're not getting paid enough is an important part of the equation. That relationship is an important part of the equation. So in Healthcare 2.0, you put 1,000 employees into Healthcare 2.0, and this is what comes out, $10 million, of costs. There's poor quality, poor service, so the denominator decreases and costs go up. So what happens to the value in that? It goes down, right? So in Healthcare 2.0, the insurance companies are trying to come up with a solution. One of them that they've come up with is a patient-centered medical home, which is going to fail. But what they're trying to do is decrease costs, but at the same time, the quality and the service is decreasing. So that doesn't help the equation, right? You understand what I'm saying? Decrease cost, decrease quality, decrease service, you still have decreased value, right? And the physician burden does impact care. It impacts quality, it impacts service. In Healthcare 2.0, the primary care physician sees 2,300 patients. It has a panel of 2,300 patients. That generates 20 to 30 appointments a day, and they have about 11 minutes per encounter, 11 minutes of face-to-face time. Now, I mentioned the patient-centered medical home. That solution is one physician supervising 5 nurse practitioners or PAs who each have 2,500 patients, and the physician has 2,500 patients. And so that's not a medical home, it's a madhouse, right? All right, so here, and this is the SALTA direct primary care model, 1,000 patients per doctor. It's a population of people that the doctor can know in a relationship and manage. There's only 10 to 12 appointments per day, and there's at least 30 minutes per encounter, 30 to 60 minutes, and that's time with the physician. Using Acid Health MD, we're taking the continuum of primary care and blasting it out the walls. So now we're interfacing with the patient when they're at home. We're assigning modules. They're doing education at home. We're communicating, hey, did you do your modules? There's biometrics being exchanged. This is your complete blood cell count. Go to the portal, you can see it. This is your health assessment. This is where you are on the health grid in terms of how healthy you are. I got your, biometrics from your Fitbit, and, I got your biometrics from your blood pressure at home, and the blood pressure's running a little high. So we're taking that continuum, and in Healthcare 3.0, it's an interface with the patient throughout, not just in the office when they come in, but whenever and wherever they are. So let's move on to the Healthcare 3.0 solution. 5 minutes? Okay.
Yep.
All right, so employers are fueling the shift from Healthcare 2.0 to 3.0. They have to make that investment by rotating money out of the 2.0 supply chain, and they're really investing in the relationship and engagement and the responsibility of the patient, because that's how we get patients to take responsibility, is through the sharing of love in a relationship, between a therapeutic relationship between the physician and the patient. These are the goals that companies have in putting a near-site or on-site direct primary care clinic. Controlling healthcare spend is the top, but there's a lot of others: reducing lost employee productivity, enhancing health and wellness, managing employee risk and chronic conditions, improving member access to healthcare. So this is the new Healthcare 3.0 value chain. Quality goes up, service goes up, costs go down, healthcare value goes up. And we save $2 million. This model saves companies 20% of their overall healthcare trend, healthcare spend, 20%. We're not just bending the healthcare trends, we're breaking. These are the attributes of SALTA Direct Primary Care: an emphasis on the patient-physician relationship, enhanced physician access, comprehensive scope of care, physician coordination of specialists, convenient locations, which include dependents. Financial incentives are aligned properly. There's a relationship between the provider and the employer for the benefit of the patient. There's consumer transparency and enhanced use of patient-centered technology. And this is the patient-centered technology, right? The engagement, responsibility, education, behavioral health is critically important. And for us, it's mindfulness. It's, we call it the relationship tool set. There's about 15 different character attributes that people need to work on in order to enhance the relationships in their lives. We incorporate that right into the office, and Asset Health does that as well. And then there's also mental health treatment, depression, anxiety, those sort of things. Physician-patient communication, biometric exchange, population management, data analytics, patient registry, and disease registry. These are all the things that patient-centered technology brings to bear. So these compare the two. So for SALTA, care is driven by the patient's needs and goals and values. Access is 24/7. The healthcare team uses patient-centered technology to its fullest. The patient can see their own physician whenever they choose. The majority of the office visit is spent with the physician. Overhead is low. Patients are seen the same day. They call the office. Physicians see 8 to 12 patients a day. The practice measures everything in their outcomes and their analytics. And the practices are proactive in the care of the patient for their chronic disease, and the physicians are satisfied and feel in control. Everything on the other side is completely opposite of that. Okay, that's in Healthcare 2.0 in the traditional model. We lower hospitalizations by 35%, specialist utilization by 40%, pharmacy costs by 45%, high-cost diagnostic testing by 50%, and emergency room utilization down by 65%. And remember this graph: would you rather be on that graph or that graph? That's what happens after we deploy a SALTA Direct Primary Care office at a company. We lower their healthcare costs by 20% and bend that curve, break that curve. So companies have to have bold leadership from the top of the company to understand their role within the Healthcare 3.0 paradigm. They need to recognize that they're not buying value from the Healthcare 2.0 supply chain, and they need to rotate that money that they can out of Healthcare 2.0 and invest it in Healthcare 3.0. Did I go over too?
You're good. You're good.
Thank you. If anybody wants to learn more about SALTA and what we can do for your company, feel free to reach our Director of Business Development, Kyle Bingham. That's his phone number there, and we'd be happy to talk some more.